other pieces that we have talked about. Okay, so hypertensive disorders are a spectrum. It's not just preeclampsia. There are a spectrum of hypertensive disorders that can occur during pregnancy. We will spend most of our time talking about preeclampsia because that is what we see most often. But I want you to remember that there is a spectrum. So we'll go through all of these, the classification, the pathophysiology.
So may I ask a quick question about visa previa?
Can you hold on to that?
Yes, absolutely.
Please. Okay. So this is basically our spectrum. You might have a patient that is a chronic hypertensive. So she had hypertension before pregnancy. You can have a patient that develops gestational hypertension. Then there's the preeclampsia, eclampsia, HELP syndrome, chronic hypertension with preeclampsia superimposed. So it can be quite complex depending on where you are along this spectrum. So starting with chronic hypertension, here we're talking about a patient who was hypertensive before the pregnancy. She was already diagnosed 2 years ago, 1 year ago, whatever it was. She was diagnosed pre-pregnancy with hypertension, or this is a patient that is diagnosed with hypertension before 20 weeks gestation and it persists after the postpartum period. So if you look at the time frame on there, it starts early and it persists after postpartum. Her body is basically telling you it was going to develop chronic hypertension even without the pregnancy. This was going to happen, okay? If anything, the stress of pregnancy just kind of jump-started the process, but this patient was going to become a chronic hypertensive patient anyway. 12 weeks is starred there because some practitioners will use 15 weeks, but 12 weeks is pretty much the average. So basically, hypertension that starts early in the pregnancy and persists after the postpartum period is considered a chronic hypertensive patient. As opposed to someone with gestational hypertension, which is a mild hypertension after 20 weeks. So I'm just going to flip back so you see this is before 20 weeks. You'll see this 20-week marker is very important, so you should kind of keep that in mind. But with gestational, we're talking about after 20 weeks in someone that was previously had normal blood pressures. Does not persist into the postpartum period. So it is truly just gestational hypertension. As opposed to preeclampsia, you can see by just how much text there is on the slide that preeclampsia is a lot more complex than gestational hypertension. So with preeclampsia, we're talking about development of hypertension after 20 weeks gestation with protein in the urine. With protein in the urine. That is the typical presentation. You may also see sometimes the patient doesn't have protein in the urine, but they will have multi-system involvement. So they may have thrombocytopenia, they may have impaired liver function, there may be other issues going on. I think I've mentioned this before, but I want to make sure that you make a note of this. Do not be deceived by the name preeclampsia, the pre. Do not be deceived by that. Preeclampsia can develop after the delivery. It can start during the intrapartum period. It can begin in the postpartum period. So do not be deceived by that pre into thinking, oh, it happens before the delivery. It can happen after. I mentioned last week when we talked about GTD, gestational trophoblastic disease, that early onset hypertension is one of the indicators of GTD. So you may see this preeclampsia developing before 20 weeks. That is always a tip off to that the patient has GTD. I'll talk about mild versus severe preeclampsia, but keep in mind any patient with severe preeclampsia has to be admitted. As soon as you see severe, you should be thinking this patient is admitted and has to be closely monitored. No patient with severe preeclampsia is being maintained in the community. It's just too risky. Eclampsia, development of convulsions, seizure activity in a preeclamptic woman. So if a patient has preeclampsia, has a seizure, they are now an eclamptic patient. Seizures can occur during the pregnancy, during labor, during delivery, during the early postpartum period.
So is eclampsia like a further complication of preeclampsia? Is it like a progression of the condition?
Yes. Mm-hmm.
Okay.
HELP syndrome. The main thing with HELP, if you can remember what the letters stand for, that will help you to remembering what is going on with HELP syndrome. So hemolysis, elevated liver enzymes, low platelets. So obviously hemolysis will result in hyperbilirubinemia and anemia, elevated liver enzymes, so elevated ALT and AST levels. Did you cover liver enzymes in fundamentals?
No, we did not.
You did not. Okay. So I usually don't really go into specific numbers, but I do expect you to remember elevated liver enzymes. And certainly do remember that ALT and AST are liver enzymes. I'm not holding you to, requiring you to know the numbers, what the norms are and so on, but that those two are liver enzymes and that their levels will increase with HELP syndrome. Epigastric pain, nausea and vomiting from the liver involvement, those occur in HELP. And then low platelets. So again, thrombocytopenia, abnormal bleeding, abnormal clotting times. And then if that isn't enough, your patient with chronic hypertension can have preeclampsia superimposed or eclampsia superimposed on top of their chronic hypertension. So again, there's a spectrum, a lot of different things that can happen with these patients. Okay, so diagnostic criteria. Basically, when you're talking about mild, and let me see. Yeah. I'm hesitating because the standards are kind of not changing, but we're seeing so many preeclamptic patients that it's getting a little bit more fluid. Basically, the numbers that we used to use that you will see in still somewhat in use, mild preeclampsia, 140/90, severe preeclampsia, 160/110. So mild 140/90, severe 160/110. So this slide is what we used to use, and it's no longer as adhered to, but I'm going to show it to you just so that you have a sense of a lot of the features and the clinical manifestations, what you are looking at when we talk about mild, severe preeclampsia. So certainly protein in the wait a minute, let me just, you know what, I'm going to hold on to the clinical manifestations. I just remembered I have a slide that has that on a little bit later, so I'll go over it with that slide. This I already mentioned, mild preeclampsia versus severe preeclampsia. There's an extra number here, sorry about that, on this slide. This should be a systolic blood pressure of 160. There's an extra one in here. It should be 160 and the diastolic 110. Sorry about that. All right. So preeclampsia, there's no specific test. It's really based on the clinical manifestation. There's nothing specific that can be said, if you do this, you won't develop it. This is a disorder that has to be diagnosed based on the symptoms, on the clinical manifestation. There is no real cure for preeclampsia other than delivery of the fetus. This is a condition that is directly associated with the pregnancy. And so the only thing that is really going to bring some resolution to this is delivery of the fetus.
That's your question. No matter which gestational age is the woman in, I mean, are you delivering the baby?
If you have a mom that is 32 weeks and the concern is that her blood pressure is 170 over 120 and her clinical status is getting progressively worse, the reality is if this pregnancy continues, you're risking the life of both the mother and the baby.
Okay. But if
so the consideration has to be to delivering this baby early and at least being able to manage both of them.
But it's different from a 25 weeks fetus because it becomes, I mean, it starts after 20 weeks of gestation. I mean, it starts early, but it manifests after 20 weeks. So it can be on a severe spectrum around 25, 26 weeks.
Can be. It can be. Typically, we don't see severe enough to deliver at 25 weeks, but it can happen. It can certainly happen.
Okay.
But we're going to talk more about clinicals.
Okay.
Presentations. So, risk factors. So, the elevated blood pressures, 2 readings at least 4 hours apart. So 2 occasions at least 4 hours apart. That will be your diagnosis. Risk factors. Advanced maternal age. We will sometimes see preeclampsia also in our younger moms. That's possible also. So either end of the age spectrum. Like many hypertensive disorders, we see a higher incidence in women of African descent, Black women in general. Our G1 moms, preeclampsia is more prevalent. And of course, if you have a history, so if she's G1 and she's preeclamptic with this pregnancy, you know she's at risk for preeclampsia and subsequent pregnancies. Moms who use assisted reproductive technology, so in vitro fertilization and those types of processes are more at risk for preeclampsia. Multi-gestational, twins, triplets, quads, and so on are moms who have high BMIs. Typically, we see this a little bit more in moms with BMIs above 30. Mothers who are diabetic, who have pre-existing hypertension, kidney issues, thrombophilia, other comorbidities, systemic lupus, antiphospholipids, antibody syndrome. We see more preeclampsia in moms with obstructive apnea syndrome. We see, let me see who else. Moms who have a history of a prior stillbirth. The next pregnancy, you have to watch them really closely. They tend to be preeclamptic, and it's possible that they were preeclamptic during that the previous pregnancy, and that's what factored into the stillbirth. All right. When we talk about the pathophysiology of preeclampsia, I need you to understand that this is not simply a matter of blood pressure. That's not the, although that is one of the main clinical manifestations, that's not what the issue is. Preeclampsia begins early, actually earlier in the pregnancy. Somewhere between week 8 and 18, as the placenta is developing. So remember, the placenta develops around week 10 to 12. So the precursor to the placenta starts developing a few weeks before, and then the placenta begins to develop. As the placenta is developing, there are alterations in the blood vessels of the placenta. That causes an inflammatory response. And there's an alteration in the way the blood vessels are formed. There are no signs and symptoms at that point. So it's early in the pregnancy. You don't see anything, you don't know anything is going on, but basically the damage has been done. So it's in the second half of the pregnancy that the inflammatory process really reveals itself, that it has caused damage to the endothelial lining of the blood vessels. And that's when you see this hypertension. So the damage is done early in the pregnancy. The patient is asymptomatic. You don't know that any damage has been done, but it's after week 20 that it manifests as this hypertension.
So you say that that generally begins between weeks 18 and 20?
8 and 18.
Oh, 8 and 18.
And then you see it after week 20. You see the clinical manifestation after week 20.
But we don't know exactly what causes it.
No.
So this,
I mean, you
this
know
is
that
an issue. Sorry.
No, I was going to say, you know that it's an alteration in the development of the placenta, but what causes that?
Right.
We don't know. Okay, so you have this endothelial cell dysfunction, and that impacts the blood vessels. So it doesn't just impact the blood vessels of the placenta. That inflammatory response impacts the blood vessels throughout the body. And that's really, what makes preeclampsia such a concern and can really make this a major problem and makes it such a progressive disorder. So this endothelial cell dysfunction causes vasospasm in the blood vessels of the placenta. So if we just think about the placenta initially, the blood vessels of the placenta are vasoconstricted. What does that mean for our fetus?
No oxygen.
So it means, it doesn't mean no, it means less, right? Reduced oxygen, reduced glucose. So this baby is going to be smaller, right? Less oxygen, excuse me, less glucose. Baby is going to be smaller. But now we have that same endothelial cell dysfunction happening throughout the rest of the body. One of the things that it results in is it makes the vasculature more permeable. So if the vessels are more permeable, the fluid tends to shift out. Sorry, fluid tends to shift out of the vessels into the tissue space. So you have fluids shifting out of the vessels into the interstitial space. So what is the result of that? If the fluid is now going into the interstitial space?
Edema?
Edema. In addition to that, if you think about it, if more fluid is going into the interstitial space, what does that do to the concentration of the blood? Of the blood itself, what's left in the vasculature? Is it more concentrated or less concentrated?
More
Protein.
concentrated.
More concentrated.
Right. So now you have hemoconcentration, which means that you have reduced blood flow to the organs. So your organs, such as the kidney, is going to have less blood flow. You're going to have less urine output. So if you think about this patient, it's not necessarily that the patient doesn't have a sufficient amount of fluid in the body. It's just in the wrong place. The fluid is in the tissues instead of being in the vascular space.
So, Professor, so how should we approach this? Would we approach it with IV fluids as well?
Oh, wait. You're ahead of me, Andres. I'm not finished telling you everything that can go wrong. There's more. Well, I'll tell you about the management in a second.
Oops.
It's right, hemoconcentrated, right, exactly. So the blood is thicker. You have this edema. Those are some of what contribute to the impaired liver function. So I already mentioned reduced urine output. So looking at this slide, we have edema. We talked about hemoconcentration. The protein, a lot of the protein, you have more protein leaking out into the urine. IUGR because of the vasoconstricted placenta. So the fetus is going to be growth restricted. We talked about the reduced perfusion to the kidneys already. So that will result in oliguria. The hemoconcentration and vasoconstriction will contribute to headaches. And I'm going to come back to this central nervous system stuff. We need to talk about that. That's really important. And I already mentioned about the liver. So a different slide with more detail, but basically saying the same kinds of things. How each system is impacted by preeclampsia. Okay, so clinical manifestations. Elevated blood pressure, we talked about. Protein in the urine, edema, we've talked about. Now, central nervous system symptoms, headaches, scotoma. So that is if you look at the visual field becomes smaller. So a blurring, a darkening of the visual field. If this should be the visual field, part of it is darkened. Blurred vision, seeing spots. Those are all central nervous system symptoms. Any patient with preeclampsia that starts having central nervous system symptoms, that body is telling you it's going to seize soon. So you have to be aware of this. Any patient that's telling you, oh, I have a headache, I've had this headache for 3 days, or they're telling you that they're having blurred vision, they're seeing spots, part of their visual field seems to be cloudy or dark, that central nervous system is telling you that it is hyperstimulated and that patient is at risk for seizure activity.
Is scotoma like tunnel vision?
No, that's what I said, the blurring of the visual field, of a portion of the visual field. You might think of it as tunnel vision. The thing is, it can be, there are different parts of the visual field that can be blurred or darkened. So if the entire periphery, is that what you're referring to?
Yeah, yeah.
There could be one form of it, but it doesn't have to be that way. It can be just 1/4 or one side.
Got it.
GI symptoms. So epigastric discomfort. Typically, epigastric discomfort is caused by liver involvement. And so it's usually referred pain from that inflamed liver. So a patient might say to you that they've had, okay, this is Monday morning, they've had heartburn. This preeclamptic patient says to you, I've had heartburn all weekend. That's telling you the liver is involved and this patient is making her way into HELP syndrome. It is getting worse. All right. So again, you have to, as I have been saying to you, always have to be on top of what are these clinical manifestations? What do these symptoms mean? What is this body? What is the patient's body trying to tell me? All right. Nausea, vomiting, epigastric discomfort. Those are all telling you liver involvement. Whatever is happening with this preeclamptic patient is getting worse. Occasionally, you'll even have a patient who is preeclamptic that has epigastric discomfort, nausea, vomiting, and they'll seize. They might not even have the central nervous system symptomatology. They might just all of a sudden seize. But all of those things, you have to realize those are telling you the situation is getting worse. So when you look at your labs, altered liver function, again, your ALT, AST, other liver function studies, your liver enzymes will be altered. Diminished renal function. How do you know that the renal function is diminished? How are you assessing diminished renal function?
It's urine output, yeah.
So the urine output of what? What specifically tells you that it's diminished? So yes, the urine output, but how are you qualifying that? What number are you using? So remember, the normal urine output is 30 mLs per hour for an adult. So when you have this preeclamptic patient and the urine output is less than 30 mLs per hour, that's telling you have diminished renal function. Okay, and then your altered coags, so your PT, your PTTs, and so on. Remember, one of the issues with preeclampsia can be bleeding, especially if it's getting worse. All right, so on the maternal end, we'll talk about what can happen, and then we'll talk about what it can result in on the fetal side. So your mom's with preeclampsia can abrupt. You can have central nervous system involvement, as I mentioned, cerebral edema, hemorrhage. These patients can have a stroke, congestive heart failure. I'll talk about this at the end, but patients who have preeclampsia can have ongoing cardiovascular disease from the damage they have sustained during the pregnancy. DIC is a complication of preeclampsia, hepatic failure, pulmonary edema, renal failure, and then, as I said, the risk of cardiovascular disease, ongoing cardiovascular disease beyond the pregnancy. On the fetal end, abnormal fetal oxygenation, we already talked about why, because of the vasoconstriction of the placenta. Fetal distress, intolerance to labor. So how is your fetus going to tell you that they are in distress? What is the fetus doing that tells you they're in distress? Fetal heart rate, say that again. Fetal heart rate, what? So, right, minimal or absent variability. What else is the fetus going to tell you?
Diminished movements.
Diminished movements, late decelerations.
Non-reassuring fetal heart rate.
Right, non-reassuring fetal heart tracing, your category 3 tracings. All of that stuff that we've talked about, you're going to see that with this patient. IUGR, again, intrauterine growth restriction. Low birth weight babies. There is a difference between the two, and we'll talk about that. I think next week we're talking about high-risk newborns. I'll make that differentiation then. But basically, just remember a smaller baby, right? Vasoconstriction, less oxygen, less glucose, smaller baby. Prematurity, again, a lot of times these babies have to be delivered early because of the mom's medical status. You will recall when we did C-sections, we talked about one of the indications for cesarean delivery was the mom's medical status. Unfortunately, some of these babies don't make it and are stillborn. So preeclampsia, again, it's not, oh, it's just a little blood pressure. Her blood pressure is a little high. This can be a major, major, major disaster. Major disaster. Okay, so any questions so far about what it can result in and the clinical manifestations before we go forward with the management? Okay, all right. So as a reminder, make sure you go back. I don't remember if I gave you this slide or not, to know what assessing edema, that you should have covered it in fundamentals, because that is going to be important to assessing your patients who are preeclamptic. So assessing lower extremity edema, assessing facial edema. And remember what I said before, ascending edema, the patient is getting worse. If the ankles are swollen, ankles and feet are swollen, the patient's in the 3rd trimester, that's one thing. But if the patient is 28 weeks, her ankles are swollen, her feet are swollen, her hands are swollen, her face is swollen, you've got a major problem. All right, so don't forget what I've said about ascending edema. And the assessment of pitting edema. Did you discuss this in fundamentals, the assessment of pitting edema?
Yes.
All right.
Professor, why in the specific, the ascending edema, I got it, that is the pooling of fluids in the extra cellular fluids. So why is because of the brain is there, the swelling in the brain? Why the ascending is worse than the descending? We always have this.
Ascending edema in any patient is concerning.
Exactly, but because
concerning.
of the brain, or because the
no, because what I'm saying to you is in any patient, if you see edema typically will begin in the lower extremities.
Okay.
So if you take, say, away from pregnancy, this is an adult patient with a renal condition. If the ankles are swollen, that's one thing. But if the patient gets to the point that the hands are swollen, the face is swollen, the patient is getting worse.
Correct. Okay.
Just
Okay.
simply in terms of gravity, right? The patient is getting worse. So definitely, if you're seeing facial edema in a preeclamptic patient, you've got a major problem here. Okay, so just another example of pitting edema. All right. So when we look at the management of preeclampsia, we have to think about what are the effects of pregnancy on hypertension. So remember everything we've talked about the increasing in vascular volume and what the volume is for, and the hemodilution that should be occurring. But on the other hand, now we have the effects of hypertension on the pregnancy. So you have two things that are kind of impacting each other. So obviously we need to monitor this blood pressure. Stay on top of the urinalysis. Now, what in the urinalysis do we need to monitor? When I say monitor urinalysis, what am I talking about? Other than the output.
Protein, presence of protein.
Protein and what else?
Hematuria?
So you're more than likely not going to see blood in the urine with preeclampsia. You will see protein. You might see a small amount of glucose just because that goes along with the pregnancy. So remember your creatinine and your BUN. Remember that from fundamentals. How important those are to your to assessing kidney function. But remember, one of your concerns with this patient is how well the kidney is functioning. Is this patient in renal failure? So you need to look at the concentration of the urine. What in your urinalysis is going to give you information about concentration of urine?
Color?
The
I
specific
need a measure.
gravity. Specific gravity.
The specific gravity. So in light of our conversation earlier, I hate to say it, but you're gonna have to go back and refresh that from fundamentals, because this is important to know specific gravity, okay? And you'll need to know it next week anyway when we talk about the high risk neonate. So urinalysis, we're looking at, first of all, at the output, specific gravity, protein in the urine, creatinine, BUN. You definitely need to know those.
I have a question, Professor. Sorry, just to reiterate, why is there protein in the urine with preeclampsia?
Because of the vascular permeability, the protein is more likely to kind of leak out into the urine.
Gotcha.
Is that related to the GFR rate? Well,
Yes.
right, because then it can't filter out that, so it just passes through.
Right. So all of it comes together. So weight monitoring, as you know, these are patients we'll do daily weights on to kind of get a sense of that, to supplement the information about edema. So we'll definitely do daily weights. I don't know what happened to my pen. Okay. Diet modifications. What do you think? What do you think we might need to modify? And I'm not talking about fluids. I'll talk about fluids in a second. But what in the diet?
The salt.
Low sodium diet.
So we tend not to restrict her to a low sodium diet. And I know this is going to sound counterintuitive, but because of the fluid issues. So if we restrict her to a lower sodium diet, this is a mom that we don't want to become dehydrated.
Yeah.
Do we give antihypertensives like lisinopril or something? Is that
So I'm going to come to that, but for right now, I want you to think about the diet. What in the diet? So take you back to your urinalysis. What was the main thing that you told me you would, that you just asked about, Fred and Alice, you asked about with the urine? The protein.
The protein.
So what diet modification do you think we might need to make with these patients?
Actually, I have to add protein, yeah, since they're losing it.
But in addition to that, so yes, they need more protein because they are losing it. And what other function can that protein serve?
I mean,
Where is your fluid? Where is her fluid?
the tissues, and that there's no protein getting to the tissues.
So how will increasing the amount of protein in her diet, which increases the amount of albumin that's circulating in the vascular space, how does that impact that? So if you have more protein in the vascular space, that protein is going to pull that fluid from the tissues into the vascular space, which is where it should be, right? So you want to give her a little extra protein to make up for what she's losing in the urine, and to try to draw some of that fluid out of the tissue into the vascular space where it should be. So you might think, well, if we draw it into the vascular space, it's only going to increase her blood pressure. But what you really want it to do, you want to get it into the vascular space and circulating so that actually it can perfuse the kidneys and be excreted.
Can you explain again how the protein is sucking that out? Like specifically, like how does that happen?
So because the protein is going to draw the fluid.
Right, why?
So if it's in the vascular space, it's going to draw the fluid out of the tissues.
I understand that, but what is the mechanic that's making it take that out? That's what I'm not getting.
Why is the,
Why is the protein drawing that out? I get that it's happening, but what is it about the protein?
Like on a biochemical level,
yes,
is what you're asking.
Yes.
It
What is
increases
it about
the osmolarity.
Right, of the protein that draws it into the vascular, the albumin, right? The osmolarity of the albumin that draws it into the that will draw it.
Thank you.
Okay. So protein modifications. Going back to, I think Andreas, you had asked me about IV fluids. You have to be careful with that. Because again, it's not that this patient is dehydrated, it's just that the fluid is not where we want it. So what you're really going to use to balance your fluids is keep a close watch on that urine output. Because you could tip her over into pulmonary edema. So you have to really watch her fluids very closely. This isn't a patient that you're going to give a lot of IV fluids to.
What would we expect the coloration of the urine to be in this case right now?
Well, that depends. Are we talking about a mild or a moderate, or? I mean, if her urine output is what it should be, 30 mLs per hour, then it should be your normal yellow urine. Once it gets less, it's going to become more amber. And once it gets more, it becomes more lighter. So we need to keep track of how our fetus is doing. So NSTs, biophysical profile, excuse me, sorry. The umbilical artery Doppler testing, again, that is testing to see what the perfusion is in that umbilical artery to give you a sense of how much oxygen and glucose the fetus is getting, so you can have a gauge for the IUGR. If this is, as I mentioned, if this is a severe preeclamptic, that's automatically in the hospital admitted, okay? 160/10, she's got to be in the hospital. 140/90, she may be managed at home, depending on what other symptoms she has. and what kind of support she has at home. If she lives alone and doesn't have someone to help her, she'll have to be hospitalized because she would have to be on at least modified bed rest. So depending on what the status is of the patient, there will be activity restrictions. So she might be on modified bed rest, complete bed rest, and then we'll need diversionary activities. So I know for myself, and probably I would guess a fair portion of you probably think, oh, I could do with like 2 weeks of bed rest. I don't want to get out of bed, only to go to the bathroom, somebody take care of me. Trust me, within like 12 hours, you'll be bored out of your skull. These patients they get bored. And when they get bored, they get cranky. And when they get cranky, guess who happens to be at the bedside? Who gets a lot of that crankiness? It's you. Yeah. So when, we try to do a lot to figure out diversionary activities, magazines, books, videos, whatever they can do on their phones, laptops to keep them entertained, so to speak. Environmental measures, if this is a patient that you have in the hospital. Okay, so I'm going to make you all the nurse manager on this floor. I am sending you from the emergency room a patient that's being admitted with a diagnosis of severe preeclampsia. You have lots of rooms open, which doesn't happen, but right now you have lots of rooms on your floor open. Which room are you putting this patient in? Are you putting her at the end of the hall? Are you putting her near the nurse's station? Which room are you putting her?
As close to the nurse's station as possible.
So close to the nurse's station. I'm seeing close to the nurse's station. Others? Anyone else?
What are all the options?
Well, you've got your pick of whatever rooms you want on the floor. I'm just saying, would you put her close to the nurse's station? Would you put her at the end of the hall?
I mean, I think closer is always better.
So most of you said closer to the nurse's station. Why? Because I always want a why. I always want a rationale. Why?
To be able to get to her as soon as possible if something goes wrong.
Okay, and I see Victoria, you're saying risk of seizure. But here's the thing and I get that. But this is a patient whose blood pressure is 160 over 110. What type of environment does she need?
Non-stressful.
Quiet.
So you want a quiet environment? Would the nurse's station be the best place?
Likely no.
Now, I'm not saying that there's a perfect answer to that question, okay? That's the life of a nurse, right? A situation like that, you do the best that you can, but I want you to appreciate that while you want the patient near, where you can keep an eye on them, certainly if they're, if they have a seizure, at the same time, near the nurse's station tends to be bright and tends to be noisy. So that can serve to further overstimulate an already overstimulated nervous system. So you have to consider all of these things, okay? So it's not just about the visitors, it's also about what we can do for the environment. So typically what we'll try to do is put these patients somewhere kind of close, but not like way at the end of the hall, but maybe a few doors down, but not as close to the nurse's station, so they're not hearing all the noise and activity. Dimmed lights, quiet room, not the room with the construction outside, like where I live right now. So you try to use whatever environmental measures that you can. Seizure precautions for these patients. Now, I don't know if you covered this or not last semester, but I want you to always keep it in your mind from this day forevermore. Anytime you take care of a patient that is at risk for seizures, you have to have oxygen and suction ready. It's got to be set up. So when I'm sending you this patient from the emergency room, that's got to be one of the first things that you set up in this room. The oxygen has to be set up and functional. The suction has to be, you have to check it and make sure it's working. Any patient at risk for seizure is a patient that's at risk for an airway issue, okay? Whether you're working in peds, you're working in maternity, you're working in geriatrics. Any patient at risk for seizures, you've got to have oxygen and suction.
What's the rationale of the suctioning? Like if they're
Airway.
So if they're like saliva gets stuck in their throat?
It could be saliva. She's not necessarily she's not going to be NPO.
Right. Okay.
Yeah. So it could just be saliva. It could be whatever she had to eat or to drink. Mm-hmm.
Okay.
Okay. But you always want to have that for your airway. So as I mentioned, the patient that is mildly preeclamptic might be monitored at home. But again, she has to have support to be able to help her. All right. If you have a patient that's being monitored for preeclampsia at home, remember she's going to have certain things in place like VNS making appointments. She would need somebody who's going to bring her in to have an NST done, to have same kind of stuff we talked about with the, remember last week we talked about the Previa patient that was being monitored on bed rest at home that needs to come in once a week to have an NST or biophysical profile. This is going to be similar to that. And then the inpatient management, I spoke about, was something else I wanted to say. Oh, the other thing is if the patient is impatient, you might have an order. Very often we'll do like maybe every 4 hours or every 6 hours, depending on the patient's status and the status of the fetus, you might have to run a strip for an hour. So run a fetal heart tracing strip for 1 hour from say 11 a.m. to 12 a.m. or from, from 3 to 4 or whatever, depending on what's going on with the mom and with the fetus, but you would expect that order. So periodically, this is how you will know what's going on with your fetus, all right? She's not necessarily going to be on 24-hour monitoring because what if you admit this patient at 30 weeks with severe preeclampsia, but she's stable at 30 weeks? She might be in the hospital. She might be with you for 4 weeks. You're not going to keep her on a fetal monitor 24 hours a day, 7 days a week for 4 weeks. Right? So if the fetus is stable, she's stable, you might just monitor her for 1 hour every 4 hours or every 6 hours, depending on what's going on. All right? All right. I think I gave you this as a handout. It's just basically what we talked about, daily weights, checking the blood pressure. I didn't mention breath sounds. You need to check breath sounds, of course. Reflexes, I'll talk about in a minute. Edema, urine output, urine protein, level of consciousness, headaches, checking the fetal heart rate and baseline variability. Though all of those we spoke about.
Are any of those did any of those take higher priority than others? Like maybe
those are all part of your, I don't know if I would say higher. Again, it depends on the patient. The thing is, these are all part of your nursing care of the preeclamptic patient. So if you have a patient that says that they have like a little bit of a blurred vision, then the CNS piece will be a little higher for you, right? If you have the patient that has a urine output of 25 mLs per hour, the renal piece is going to be a little more for you. So, it really just depends on what the patient is doing.
Okay, thank you.
Okay, deep tendon reflexes. I hate to keep asking you, but I have to make sure that you know. So if you don't know this you absolutely have to know, because this is important to preeclampsia. All right. So remember what I mentioned about the central nervous system. So if you have a patient, let's say you have this patient who is admitted, severe preeclampsia, is having headaches. She calls you in because she's having a headache. You know, the headache feels a little worse. And so you have central nervous system kind of prioritized on from this list, right? Because she has this headache. She tells you the headache is a little worse. You check her deep tendon reflexes. What would concern you? Preeclamptic patient, severe preeclamptic patient with a headache. Which deep tendon response are you most concerned? What are you concerned about? Plus what? I'm sorry? So I want a number. Give me a number. Give me a specific. So Sarah, you're saying a +4. Yes, and the thing is, you've already got an overly sensitive central nervous system. If you get a +4, what is that body telling you? I am going to seize. That is what it's telling you. You've got to use all of your clues in your little detective life here, right? If the patient has hyper reflexes, deep tendon reflexes, that is telling you central nervous system is really overstimulated. You always want to catch these patients before they seize. You don't want it to get to a seizure, okay? Now, part of the reason that this is so important is because we treat a lot of these patients with magnesium sulfate as an anticonvulsant. So I'm going to talk about this, but first I just want to mention the antihypertensives. Zachary, you had asked me about this earlier. Whether or not the patient needs an antihypertensive will depend on the patient's history. If this is a chronic hypertensive patient with preeclampsia superimposed, she might already be on a medication for her blood pressure. But let's say this is the patient that has no BP issues until the pregnancy, you might or might not need to treat her with an antihypertensive. And I'll tell you why. Well, I'm not going to tell you why. You're going to tell me why. Magnesium, what is the effect of magnesium on the smooth muscle?
It relaxes smooth muscle.
It relaxes smooth muscle. Now, I'll come back to the anticonvulsant piece. But if you think about it, the arterioles in the body have smooth muscle, right? So when you give magnesium, this is not the primary reason you're giving it. You're giving it as an anticonvulsant, but like a little side bonus, so to speak, is that it relaxes the smooth muscle. So it will contribute to lowering the blood pressure, right? But that's not why you're giving it. It is not an antihypertensive. You're not giving it as an antihypertensive. You're giving it as an anticonvulsant. You just get this little extra benefit from it. So sometimes when you put a preeclamptic patient on magnesium sulfate as a anticonvulsant, you don't need to give her anything for the blood pressure because you get this little added benefit that lowers the blood pressure a little bit. All right, so magnesium sulfate. So we give it as an anticonvulsant. Now, the concern, I'll come back to that. the concern with magnesium is it relaxes the smooth muscle, but it can relax everything else. So you have to be really careful with this. It's a heavy duty medication. You have to be really, really careful with this. A patient can easily slip from a therapeutic level to central nervous system depression, to respiratory depression, to coma, to death. So it's on us to make sure we're on top of these patients. So any patient that's on magnesium sulfate, you have to keep your reflex hammer with you. Every time you go in, you have to check these reflexes. Because once you see the patient, let's say that patient that we had that was +4, a few hours later, she's +2, that's okay. We want her there, but we don't want her getting to +1 because that means that she's becoming toxic from the medication, all right? So any patient on magnesium sulfate, you have to stay on top of these deep tendon reflexes. You will see a change in the deep tendon reflex before you see a change in the respiratory status. So once you see the patient starting to get very sluggish, very somnolent, not responsive, you know that you've got to do something, all right? Let me just say this about the magnesium levels. This is just from one resource. Every book you look in is going to give you a different, it's going to be like a difference of like maybe 0.3. I don't want you to get so much tied up in the numbers as I want you to remember that we need to keep the patient in a therapeutic range and not to let them become toxic, all right? Again, toxicity, you're going to see respiratory depression, depression of the deep tendon reflexes, lethargy, weakness. Some patients will have diarrhea. Again, the relaxation of the smooth muscle. Some patients will become flushed. When you look at your strip, remember this magnesium is crossing the placenta to the fetus.
Professor, sensation of flushing means flushing in the face.
Yes.
What you
Yes.
said. Okay, thank you.
The fetal heart rate variability will become diminished. This fetus will become hypotonic. So, I'll do all of that. The only one I didn't mention, remember your urine output, the oliguria, right? It can, again, diminish, relax the muscle and diminish the urine output. The antidote to magnesium sulfate is calcium gluconate. So any patient on magnesium, the two things you have to have with you, mag sulfate and your reflex hammer and your calcium gluconate. I already mentioned the resuscitation equipment. Make sure you have that readily available. So any of these patients should have oxygen and suction set up. The calcium gluconate has to be readily available. It cannot be locked in the cabinet and the person who has the keys just went to Starbucks. That is not going to work, all right? You have to have it readily available. Okay, before I talk about how it's at the magnesium, how it's actually given, are there questions up to this point?
Yeah, so CNS depression comes before respiratory depression, right?
Yeah, you'll see the central nervous system depression before.
Mhm.
So that's why you really stay on top of that. Because once you get into respiratory depression, you're already in trouble. So you always want to catch it before.
Professor, I guess for me, I'm just wondering the main difference between the preeclampsia and hypertension would be the preeclampsia has the presence of protein in the urine. Is that correct?
And when it begins.
And when it begins.
Are you talking about chronic hypertension?
I guess any sort of hypertension during pregnancy. I guess I'm just wondering why it would be preeclampsia instead of regular
So you
hypertension.
have to, so remember, your chronic hypertensives typically come in already diagnosed.
Mm-hmm,
They've
yeah.
had, you know, hypertension for 3 years, 4 years, whatever it is, and now they're pregnant.
Mm-hmm.
The
So once it's
preeclampsia starts after 20 weeks gestation. Because remember, it's related to the formation of the placenta. So you don't see it until after 20 weeks gestation.
okay, so could you have hypertension that starts during pregnancy and it not be preeclampsia?
It can be gestational.
Okay, and then the difference with that is there's no proteinuria. Okay, got it. Thank you.
All right. So other questions before we talk about magnesium, the infusion of magnesium. Okay. So when you start a patient on magnesium sulfate, typically you will give a loading dose, which is usually 4 to 6 grams over 15 to 20 minutes. So you have the one bag. And I think what I'll try to do is I'll maybe write out a scenario for you and put it on Blackboard so that you can kind of process it through step by step. So this one bag, you give 4 to 6 grams over 15 to 20 minutes. So that rate is going to be whatever the rate is, and then you reduce the rate so that the patient is now just getting 1 to 3 grams per hour. So it's the same bag. You don't change the bag. The bag is connected. You just give a higher rate so that you give the loading dose because you want to try to get that magnesium level up. And then you give the maintenance infusion. Okay. All right. All right. So hopefully our preeclamptic patient does not advance to eclampsia, but sometimes they do even with magnesium sulfate. So again, it's always, safety is always, you know, your priority, but always keeping in mind what the risks are. So which patient is more likely to seize? Again, the patient that is having more central nervous system symptomatology. So remember your ABCs. Again, any patient at risk for seizure, have your suction and oxygen ready and available. How much about seizures did you cover in fundamentals? Do you know what a post-ictal phase is? Or is that like?
No.
Yeah, I think we went through that.
Oh,
I
oops.
don't. Or maybe.
I
don't
don't think we went through that. I was in a different class from everybody else.
I don't.
So
recall
go ahead. Say that again.
I said I didn't recall that we did any seizures at all.
All right. I'll see if I'll post something that's just very basic about seizures for you. But typically what you will see in a preeclamptic, in an eclamptic patient is a more of a tonic-clonic seizure. I'll post something about that, but here's what I want you to remember. Most patients, when they have a seizure, the first thing is safety. Protect the patient's head, because I'm telling you, this will happen to you. We all live in New York City. People have seizures on the street, on the subway, in the supermarket. Protect the patient's head. Most seizures are self-limiting, so it's a matter of safety. Make sure that when the seizure is happening, the patient doesn't hurt themselves. They don't hit their head. I always say, remember that very often patients will lose bowel and bladder control. So try to be respectful of that. You know, if they have like a jacket or a scarf or something that you can just cover them with to, protect their dignity. But again, most of them are self-limiting. After the seizure, most patients will have a post-ictal phase where they're just like very sleepy, very drowsy. They might be really hard to arouse, right? It's almost, you just kind of let them rest. As long as their airway is okay, you just let them rest, right? That's basically what the post-ictal phase is.
Spell that in the chat.
I'm sorry?
You post that in the chat. There's the spelling of post whatever ictal.
It's on the
It's
here.
slide.
Oh, Jesus, sorry.
Yeah, the post-ictal phase. So the reason that I'm mentioning it is that very often, if you've never seen a post-ictal phase, it can be very alarming, like you can't wake the patient up, but this is perfectly normal. It's like a very deep kind of drowsy, sleepy state, all right? So you should expect that. Okay.
How
Now-
long would that last usually?
Depends on the patient. Maybe 5 minutes. It's
Oh,
not
okay.
very long.
It's not, okay, got it.
It's not very long, maybe 5 minutes. And then it's like the patient comes like they're coming out of a really deep sleep, right? So they might be very sluggish. They might be a little confused. They might not remember what happened. It might take a few seconds to realize, oh my gosh, I was in the supermarket. Did I have a seizure? Because very often patients that have seizures, they know their own history. All right.
Does the length of the post-ictal phase correspond with the length of the seizure?
No. Mm-mm. And remember, most seizures aren't very long. When it's happening, it feels, I don't know what it feels like as a patient because I've never had a seizure, but watching it, I can tell you it feels like it lasts for an hour. Typically, it's about a minute, right? It's about a minute, 2 minutes, but it feels like, oh my gosh, it feels like hours. So, okay, if you are in the hospital, you certainly want to put the patient, you want to get a strip immediately because there can be issues with oxygenation while the seizure was happening. The mom's oxygenation might be diminished. And remember, if her oxygenation is diminished, fetal oxygenation is diminished. So some of those issues can lead to this uterine irritability. Sometimes mom will have a seizure, her membranes will rupture, contractions will start, she will abrupt. Any of those things can be triggered by this seizure. So you want to make sure that you get a strip immediately. Okay. So now we're in labor and delivery, finally. I know you thought it was all over, but it's not. So we're finally in labor and delivery with this patient. Again, monitor very closely. Most seizures that happen, they happen during labor or that first 24 hours after birth. So don't think, oh, now we're in labor and delivery, we're home free. We're not home free. This is really when these patients tend to seize. Okay, so now we're in labor and delivery. Patients on magnesium sulfate. You told me that magnesium sulfate relaxes the smooth muscle. What does that mean for the contraction pattern?
Relaxed.
Reduced.
It's going to be reduced. The contractions are going to be less effective. So now we need to give oxytocin to augment the labor. So I know it's intellectually, it seems like you have two opposing forces, but you have to understand why we're doing what we need. The magnesium to prevent the seizures, but the magnesium is reducing the efficacy of the contraction. So now we have to give the oxytocin. But remember, patients who are on oxytocin are at risk for water intoxication. And now we have this patient that has maintenance IV fluids, magnesium, and oxytocin, and a blood pressure issue. and renal perfusion issues. So those of you who couldn't wait to get to unit 3, here we are. Aren't you happy? This is what you wanted. These patients are challenged.
Delightful.
I'm sorry?
He said delightful.
Yes. These patients are challenging. This is why you have to take your lunch to work, because trust me, the days that you think you're going to go out for lunch, this is when you get these patients and you end up not eating. Do you not have this slide?
We do.
No, we haven't.
Find it. I don't see it.
It's here. It's just above HELP syndrome and below management of eclampsia.
I'll find it. Thank you.
Okay, so all of that to say, you've got your work cut out for you. So these patients, you have to stay, right on top of them, okay? If this is a patient that's GBS positive and you need to give penicillin, that's another line, right? So you're constantly titrating, what you're giving with what's compatible with what. Now your oxytocin is a continuous infusion. Your magnesium is a continuous infusion. Your maintenance IV fluid is a continuous infusion. So you might actually need 3 lines for a patient that's GBS positive, right? And you piggyback your penicillin into your lactated ringers. Now, what if the patient's in a lot of pain and we give the patient wants an epidural? So remember what can happen with the epidural and the blood pressure issue, right? So do we pre-bolus this preeclamptic patient who's 160 over 110 with 500 mils because the blood pressure might bottom out? This is what I'm saying to you. It is very complex. It's very, very complex. So you really have to consider how are you going to do all of this? This is not the type of patient that it's like, oh, just, Simona's a nurse, she'll figure it out. This is why I say to you, we take care of these patients as a team. You have to, because there's so many pieces to consider.
I think this is a perfect example of one that, like, I could totally see you doing a test question on this, but.
Well, okay. You heard Fred said that, right? So I don't want to hear any complaints about the question that I put on the exam. This is on you, Fred.
Well, no, I stand by it, but it's like, what my point of that comment was is like,
Yeah.
okay, I need help thinking through this one, because this can go in so many different directions. I need practice in those directions,
Mm-hmm.
because it's like, that's a lot.
It is a lot. And quite frankly, would I give you a patient that's preeclamptic on MAG with a pit drip, that's GBS positive and has an epidural? No. That to me would not be, I wouldn't give any student a question like that. That's a question that I would give, when I teach nurses in the hospital. That's a question I would give them. That's not a question I would give you, because that's just like a brain burster kind of a question. I wouldn't do that. It's too much, and quite frankly, it's too much to even write into a question. It's a case study, really. That's more of a case study. The case that I'm thinking of that I will probably post for you doesn't even have that much, but the point is that these are all things that you have to consider. And I know I've mentioned this before, but again, these are the patients that you make sure the NICU knows that we have this patient. So you don't even wait until the patient might need to be delivered, right? Once you have this patient on labor and delivery, even if it looks like, what time is it? Even if it's about noon, even if it looks like this patient might not deliver until 6 p.m., you already let them know that this patient is here and what's going on, so that they can start preparing for this patient.
Question, okay? Professor?
Yes.
Just about opiate analgesics and epidurals. What should we consider about those, like in any ways that they can complicate this already like very complicated situation Like, are there
So
any?
remember the epidural, what we talked about, what can happen with the epidural and the blood pressure bottoming out when the epidural
Yes,
is
the hypotension, right?
right. And that's what I was saying. But would you necessarily pre-bolus a patient who has a blood pressure of 110/60
Okay.
with half a liter of fluid, right? You have to really think about that with your team carefully. If this is an opiate analgesic, if you give this patient an IM injection of morphine, how might that impact the fetus?
Well,
Mhm.
they're already taking magnesium sulfate that you said is a CNS depressant, and then plus the opiate that's a CNS depressant. So you have to have the naloxone ready for the baby, right?
So you definitely have to have, yes, you do, but I want you to remember you have to have more than an naloxone because, okay, so let's think about these two things. What is the magnesium, what is the effect of the magnesium going to be on the respiratory effort of this fetus?
It's going to depress it.
Plus the morphine.
The same thing.
So even if this baby is born and needs naloxone,
Oh, chest PT.
no, even if the baby is born and needs naloxone, you might be able to reverse the morphine, but the baby still has magnesium on board. So the respiratory status is going to be depressed. Right. So this is why you really need to have a team there to resuscitate this baby.
Got it.
Are you
Okay.
gonna give I mean, oh my goodness, sorry. Are you gonna give to counteract the magnesium to a baby the calcium gluconate?
You just let the baby metabolize it out.
Oh, so
Right.
no glucose. That is only for the mom, just in case of the toxicity. Okay.
Good question.
Now, the other thing is, okay, so I'm the labor and delivery nurse. I've taken care of this mom, and you are the nurse that's in the nursery. When I call and give you a report that I'm sending you this baby, and the mom's been on mag sulfate since Friday afternoon, I shouldn't have to tell you this baby's coming with a depressed respiratory status, right? Baby may be breathing, but we said normal was 30 to 50. This baby may be closer to 30 than 50, which means you have to watch this baby. So the baby may not be depressed enough to go to the NICU, may be stable enough to come to the nursery, but you got to stay on top of this baby. Okay? So these patients don't, I don't want you to think, oh, they'll always go to the ICU. I'll never have to deal with this kind of situation. All right? Okay. All right. So in case you haven't had enough fun with preeclampsia, see how much fun you can have with HELLP syndrome. So let's say you have a mom that's preeclamptic and advances to HELLP. Occasionally you'll have a mom that'll come in and just, you know, she might seem like she's preeclamptic and she'll just shoot all the way to HELLP, right? To HELLP syndrome. Again, this is the result of the vasospasm. So you have a mom now who is anemic, who is truly anemic because of the hemolysis. So hyperbilirubinemia, you're going to draw her serum bilis. You're going to get elevated bilirubin levels on her. She might have a jaundiced appearance. So particularly to her sclera, she might have a jaundiced appearance. Again, elevated liver enzymes. Low platelets, she's going to bruise very easily. I think I already mentioned that these moms will go into DIC on you very easily. This is enough to trigger that cascade into DIC. There was something else. Oh, assessment. So one thing that's important to remember, moms who have HELLP syndrome, the liver can become encapsulated. So it's edematous, it can become encapsulated. You cannot do abdominal palpations on these moms. That liver can rupture. And then you have a massive surgical emergency on your hands, all right? So be very, very careful with that.
Why does the liver do that?
it becomes encapsulated because of the arterial changes that are happening, because of the endothelial lining changes and the inflammatory response.
Okay.
The liver becomes swollen and encapsulated.
What specifically is it encapsulated in?
The membrane, but it becomes swollen and it
Harder.
yeah, it's because it has like a thin
Membrane.
membrane. There's like a thin membrane, but it becomes so swollen and
Fragile.
yeah, it is definitely fragile, but it becomes so swollen that it can rupture.
Gotcha.
Yeah.
Sorry, one more thing, Professor. What's the what's the difference between like severe preeclampsia and HELP syndrome? Are they
So severe preeclampsia, the blood pressures are 160 over 110.
mm-hmm.
HELP syndrome, this is HELP syndrome. When you have these,
right.
that's HELP. So you can have a severe preeclamptic with HELP.
With HELP.
You can have both.
Can you have someone with mild preeclampsia with HELP?
With HELP, yes.
Okay.
So you guys like all of this stuff. You can have all these wonderful complications together. You certainly.
Professor,
We're all gonna get 100.
only these are for half of our test, right?
Huh?
Only these syndromes are half of our exam already, right?
Well, don't forget everything we talked about previous and ectopics and DIC and yeah, complications is complicated. So HELP syndrome, now occasionally you'll have a mom who just comes in and she just jumped past everything and went straight to HELP, okay? Some of the signs and symptoms, she may complain of flu-like symptoms. In this time of year, you have to really zero in on this and don't just think, oh, she's got a cold, oh, she's got the flu. She may have HELP syndrome. So you have to ask her these extra questions. Have you had any heartburn? Do you have any, you don't say right upper quadrant, just discomfort. They won't know what you're talking about. But, you explain to them where you're speaking about and see, because sometimes you have patients that just present straight away with HELP syndrome. Now, unfortunately, like preeclampsia, we do lose patients to HELP syndrome. So it's really important to make sure that we are on top of this. Last fall, during clinical, we had a patient that started out in labor and delivery with severe preeclampsia, HELP. She had a section, ended up in the ICU. She was in the ICU the entire length. She delivered our first week. The entire length of our clinical, she was in the ICU because she went into DIC. Preeclampsia, HELP, DIC, in the ICU for a month. Well, her baby was fine, did fine. Baby was premature, but in the NICU, but did well. So this is crucial stuff. All right. Postpartum. So again, careful assessment of mother's blood loss. So here's a question for you. You told me magnesium sulfate relaxes the smooth muscle. What does that mean after delivery?
Risk of hemorrhage.
Risk of postpartum hemorrhage. She might need some more oxytocin, but she definitely needs her nurse to be on top of that fundus, checking that fundus, checking that fundus, checking that fundus, okay? Remember that preeclampsia, any patient, preeclampsia can start late, it can start in intrapartum, it can start postpartum. A patient that was mildly preeclamptic can become worse. Patient that was preeclamptic can become eclamptic, they can see it. So we have to always have our radar up. Patients who are preeclamptic, again, the delivery, remember I said once the patient delivers, the body will start to heal, right? You will see an increase in urinary output. The protein in the urine will diminish. The blood pressure will usually start to settle back. But be alert that preeclampsia is an established risk. Research shows these patients are at risk for cardiovascular disease going forward. So any patient that has a pregnancy complicated with preeclampsia, they need annual follow-ups, checking and they need to stay on top of their weights, blood pressures, lipid profiles, and checking their fasting glucose levels and their hemoglobin A1Cs.
So after 48 hours, they should be in the clear?
After
48 hours? Should be is the thing there.
yeah, you know, I mean, the risk of them seizing and getting worse goes down, but yeah, but you have to still, you know, you got to watch them. You got to watch these patients closely. So, questions?
Yes, just really quick on one of the last slides. I'm sorry if I missed it. What's the difference between incomplete partial HELP and ELLP syndrome? Yeah.
Oh, okay. So I'm not going to hold you to this. This was more of an FYI, but but basically patients might not present with all of the components of HELP. So then that would be considered an incomplete. So let's say they have hemolysis. Oops, I went the wrong way. They have hemolysis and elevated liver enzymes, but their platelets are okay.
Okay.
Other questions? So I know that's a lot to take in. As I said, preeclampsia is very complex. And as I said, I spent the bulk of the time on preeclampsia because when you look at the spectrum, that's mainly what we see is preeclampsia and HELP syndrome. Okay.
Professor, I do have questions about what you had previously covered on the last lecture, because that's what I was reviewing. Do you want me to ask now, or do you want me to ask?
Oh, you had a question about if you can hold on to your question until tomorrow, because that vasoprevia is going to come up again tomorrow.
Okay, yeah, I had a question about vasoprevia and about the placental abruption.
So tell me your abruption question, but if you can hold on to the previa question, then that will probably tie in with what we're doing tomorrow.
So in terms of the different grades of the placental abruption, is the grade 3 always concealed?
Not always.
Because if you look on the diagram that you gave us.
On the diagram, it's concealed.
Okay, so it doesn't necessarily.
Usually you don't have like a huge, massive bleeding with a grade 3, because usually the volume of bleeding, what tends to happen is there's a clot that will form that prevents the bleeding from coming out. But at grade 3, you might have a small amount of bleeding.
Mm-hmm.
So it's mostly concealed, but understand that the volume, it's a large volume of bleeding though, even though it's concealed.
Okay, so a grade 1 would be a small area.
Mm-hmm.
Grade 2 would be a medium amount of area, and then a grade 3 would be a large area.
Or total. Mm-hmm.
Or total.
Mm-hmm.
But the amount of bleeding would vary. But I mean, probably the grade 3 is going to have the most bleeding.
Right. The amount of bleeding corresponds with the amount of separation. Yes.
But the bleeding can be either concealed or not
With the grade
on
3,
any of the grades.
grade 3, typically it's concealed. You might have a small amount of bleeding that comes out, but it is mostly concealed.
Okay, that, and the same for grade 1 and 2?
You tend to see more bleeding. You will see more bleeding.
Okay,
Yeah.
and 1 is less.
1 is less.
So 1 and 3 are less bleeding, and 2 is a lot of bleeding.
No. 3 is a grade 3 is the most separation,
Mm-hmm.
the most bleeding,
Mm-hmm.
the most pain, the most bleeding, the worst outcome. The
Okay.
grade 3 is just all the way the worst
Mm-hmm.
of the lot. Let me see if I can find the
But you would see less of the bleeding. I guess I'm trying to find it too. It's just because the grade 2, it showed, I guess, blood coming out of the vagina. And I think that's what's confusing me, that there would be no blood coming out for the grade 3 and the grade 1, or less blood. That's just what I was a little confused about.
but you might not
Yeah.
have. So remember how I said to you, you cannot always rely on, in the wrong one. You can't rely on what you will see.
I guess it's based, these 3 is based where the placenta is implanted. The second one, the medial is more lateral implanted. So of course you will have more bleeding, even if it's a second, I mean, this is
Not really related to the implantation,
Okay.
actually. No, it's more a matter of where the separation has
occurred. Okay.
occurred and how much separate. Not so much where it implanted, but how much it's
I mean, in this one, this is how I read it.
So where the actual separation is
not necessarily. Not necessarily. It may be concealed, it may be visible.
okay.
It may be concealed, it may be visible.
Okay. So, and that has nothing to do with the degree.
So for instance, if you have, let's say you have a patient that has a grade 3 abruption, 90%, 95% has separated. So essentially it's just about completely separated.
Right.
That is massive bleeding,
Mm-hmm.
but it may be completely concealed. You might not see any of it. It's a large amount of blood loss, but you're not seeing it.
Okay.
So remember how I said don't expect to always see blood, even if
Right.
your patient's having a massive hemorrhage.
It's just going to depend on the situation.
Yeah.
But it's, yeah. Okay. Got it. Got it.
Okay. I guess that everybody's brain is probably sufficiently scrambled, or at the very least saturated from preeclampsia. Tomorrow, we'll see how we'll get through. We need to, we were supposed to do diabetes today. That is actually shorter in comparison to hypertensive disorders. And again, a lot of it we have, we've talked about. So that, and we were scheduled to do intrapartum complications tomorrow. So we'll certainly cover diabetes. I think we'll get through intrapartum complications. We're not going to get to infections. So I'm going to have to move on to plan C for infections. All right, I'll update Blackboard. I'll have to think of something for that. The case, as I mentioned, is there for Chelsea There's one case that's there. I'll try to put up some others as this week as we go along. The other things I'll have to figure out and get back to you about, as I said earlier. But I think that's it for now, I think, unless there are any other questions or
The chat.
comments. HPS, as of right now, 12:30 on Monday, yes, HPS is still happening. But the reality is that things can change on a daily basis. So as of right now, yes.
You just
What
said,
might happen tomorrow?
No, Professor,
I have
no.
no idea.
The HPS, not Monday, 12:30. No, I don't think so. Is the
so on Thursday.
Thursday.
It's next week, Thursday.
She just meant as of like right now.
Oh,
As of right
Oh,
now,
okay, sorry.
yes, it is as scheduled. What
Okay.
is going to happen next week? I don't know. Right now, we're just going day by day. We're going day by day. The scenario that I have in mind for you has to do with postpartum, so we haven't even covered it yet. Unless I could change it to the preeclampsia, but I'll think about that. But I was planning to do the something to do with postpartum, but again, it just depends on what happens next week. Okay. Okay, so I know I have appointments with a few of you later. I will see you then. I will have office hours at 1. I'm just going to log off and get something to drink, a little snack, and then I will be back for office hours from 1 to 2. Okay.
Thank you.
Okay.
Thank you,
Have a
Professor.
good day. I will see the rest of you
Bye.
tomorrow.
All right, thank you.
Yeah.
for
Bye,
that.
guys. Bye,
You're
Professor.
welcome. Bye.
Thank you.
Okay, see you later.